Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. Today in my lesson I'm going to talk on beta thalassemia major. Beta thalassemia major is one of the thalassemias, and thalassemias are the genetically transmitted diseases with chronic hemolysis, and they are transfusion dependent chronic hemolytic anemias associated with the reduced or absent synthesis of the hemoglobin. The defect lies in the mutation of the gene that controlling the synthesis of globin chains of hemoglobin. It could be alpha chain or beta chain. Mutation of the alpha chain results in the reduced or absent synthesis of the alpha chain, resulting in alpha thalassemia. And defect in the gene controlling the beta globin chain results in the absent or reduced synthesis of the beta globin chain, resulting in beta thalassemias. Okay, this disorder is inherited by autosomal recessive pattern of inheritance, and the individual receives one abnormal copy of the gene from each parent. So homozygosity will manifest. There is a quantitative defect in the hemoglobin synthesis. These disorders are beta thalassemia major in particular is transfusion dependent, causing morbidity and mortality. Look at this child, male child aged 7 years from Middle Eastern countries, showing marked bossing of the forehead and parietal bossing and prominence of the zygoma, giving a mongoloid appearance. This is the child suffering from beta thalassemia major. Well, thalassemia is genetically transmitted hemolytic anemia associated with diminished or absent production of the beta globin chains with variable clinical presentation. There have been nearly 200 beta thalassemia variants. Nearly 3% of the world population carry the gene for beta thalassemia. This is the most common genetic disorder. Well, the disease is related to geographic distribution of malaria. Red cells, they have the reduced lifespan, and there is higher concentration of fetal hemoglobin, ineffective erythropoiesis, and the disease is transfusion dependent and complicates transfusion related hemosiderosis. And how to go about this? What is the what are the genetics of various thalassemias? Well, what is the clinical presentation? How to manage the child with thalassemia major? We are going to talk in detail about each aspect of this particular beta thalassemia major. This is genetically transmitted disorder with autosomal recessive inheritance. That means homologous state manifests. Heterologous state, the individual is carrier. Okay. If both the parents are carriers, there is 25% of the chances of the individual child being affected. As such, it could be heterozygous is a carrier, homozygous manifests the disease, hemizygosity is a double mutation with the other hemolytic anemias like sickle cell, HBC, etc. And thalassemia, that is beta thalassemia, as such manifests as thalassemia major, thalassemia intermedia, thalassemia minima or minor, or thalassemia trait. Okay, this all varieties are because of the degree of genetic mutation that results in the quantum of the beta globin that is produced. There are beta gene clusters on the chromosome 11 at sixth position. Okay, epsilon 1, gamma 2, and beta 1 and delta 1 are the beta related genes. That means there is one gene for epsilon chain, there are two genes for gamma globin chain, and there is one gene for beta globin chain, and there is one gene for delta globin chain. Okay, epsilon, gamma, beta, and delta are related to beta globins. Okay, for example, there is epsilon, okay, pairs with the lambda to form the Gover's hemoglobin or embryonic hemoglobin. Then there is alpha 2 and gamma 2 is the configuration for fetal hemoglobin. Then alpha 2 and beta 2 is the configuration of adult hemoglobin. Okay. So, and alpha 2 and delta 2 is A2 hemoglobin, right? Epsilon, gamma, beta, and delta are the products of beta related genes. Okay. So let us talk about the beta thalassemia. Okay. Beta thalassemia is due to reduced synthesis or absent synthesis of the beta globin chain, okay, due to the mutation of the beta genes, right? Yeah. One beta gene on each chromosome inherited from each parent. Okay. So there are two beta genes that produce the two beta globin chains. Okay. There are two alpha globin chains and two beta globin chains in adult hemoglobin. And HbA2, the configuration of HbA2 is alpha 2 and delta 2. Okay, right. B/B represents the genotype for normal beta chains. So this you please understand in order to know the genes that control the production of globin chains. Beta globin chains are the products of beta genes. And there are two beta genes inherited from one from each parent. And there are two beta genes controlling the two globin chains in the adult hemoglobin, which in combination with the two alpha globin chains form the adult hemoglobin. Okay. In the event there is reduced production of the beta globin chains or absent formation of the beta globin chains as a result of the mutation of the genes that control the synthesis of beta chains, there results in the imbalance in the quantum of the alpha globin chain and the beta globin chain. Okay, that leads to the manifestations of beta thalassemia, which we are going to talk in the pathogenesis. What are the genetic abnormalities? Beta 0 is homozygous thalassemia major. The same way, beta plus indicates reduced synthesis of beta globin chain. Beta 0 means totally absent beta chain. Well, beta plus and beta plus is again homozygous, results in thalassemia major with variable manifestations. Then beta 0 and beta plus, again homozygous. Homozygous because there is one globin chain is totally absent, another globin chain is in reduced quantity. Okay, so this is again homozygous with respect to the mutation of the genes. Both the genes are abnormal in beta 0 and beta plus, resulting in the totally absent one globin chain and reduced quantity of the another beta globin chain. But the defect is in both the genes inherited from the parents. So that's why it is homozygous. It results in thalassemia intermedia. Right? So thalassemia major, thalassemia intermedia are homozygous states. Okay. Thalassemia minor and minima. This is because of the presence of one beta gene normal and one abnormal beta gene. Normal beta gene, its product is normal beta chain, and beta 0 results in the result of the abnormal gene. That results in the beta 0 and beta, a heterozygous state that results in thalassemia minor or minima. Then beta plus and beta, this is again heterozygous state. It is the feature of thalassemia trait. Okay. So you have got thalassemia trait with a beta plus and beta, a heterozygous state, thalassemia minor or minima with beta 0 and beta. It is again heterozygous state. Thalassemia intermedia and thalassemia major are homozygous states. Okay. This is the molecular basis of thalassaemic syndrome, beta thalassemia. But there are nearly 200 genetic variants of beta thalassemia, out of which few manifest. What exactly is the genetic basis and the pathogenesis of this particular genetically transmitted hemolytic anemia, that is beta thalassemia? The defect lies in the DNA. Okay? And there is beta gene mutation. What is gene? Gene is a segment of DNA. Okay? DNA is clustered in the nucleus of the cell, forming the thread-like structures called chromosomes. Okay? A particular segment of the DNA is called gene. The locus is the point on the chromosome where the gene is abnormal. Okay? The genes for the beta globin chains, that is beta globins, are located under the chromosome 16, chromosome 11 at 6th position. Okay? There are two genes for um, gamma globin chain and one gene for beta globin chain. Okay? So the individual inherit this one gene from each parent that control the synthesis of beta globin. If there is a mutation in the gene, there is reduced synthesis of beta globin chain, thereby resulting in thalassemia. So when there is a mutation in the beta gene, there is absent or diminished beta gene product, that is beta globin chain. Well, when there is excess of alpha gene product, that is alpha globin chain, and it results in the alpha globin tetramers. Well, these alpha globin tetramers that are produced in the red blood cell, they form inclusions. They get into inclusion bodies that will result in the damage to the cell membrane, so hemolysis, right? So the RBC, before they are released from the bone marrow, they are destroyed in the bone marrow itself. Okay? RBC destroyed prematurely within the bone marrow. So this phenomenon is called ineffective erythropoiesis. That means the erythropoiesis that is occurring from the erythroblast to the matured RBC, it will not progress normally as it happens in the normal individual. Okay? The phenomena of erythropoiesis will not progress to the formation of normal RBC. It will take longer time. And the RBC are destroyed within the bone marrow before they are released into the circulation. Okay? So prolonged stay of the RBC during the process of erythropoiesis results in the microcytic anemia. Okay? And as a result of continued destruction of the RBC within the bone marrow, results in dramatic fall in the hemoglobin concentration. Hemoglobin is responsible for carrying the oxygen to the tissues. So, fall in the hemoglobin content results in hypoxemia. Hypoxia stimulates the production of erythropoietin, which results in erythroid hyperplasia, okay, and widening of the marrow place. Excess gamma and delta genes, they produce elevated HbF and HbA2. HbF, what is the configuration of HbF? Two alpha chains and two gamma chains. Because there is no formation of the beta globin chains and the gene controlling the beta globin chain is defective, there is overproduction of the gamma chains and the alpha chains, forming the elevated levels of fetal hemoglobin and tetramers of the alpha chains. Tetramers of the alpha chain form the inclusion bodies in the RBC, cause the damage to the membrane of the RBC, thereby resulting lysis before they are released into the circulation. This is called ineffective erythropoiesis, which results in hypoxia, stimulation of the production of erythropoietin, which in turn results in the erythroid hyperplasia. Well, as a response to hypoxia, second to the fall in hemoglobin concentration, there is increased absorption of iron through gut. This is because of the production of erythroferron by the liver, which facilitate the increased absorption of iron from the gut, and in turn suppresses the production of hepcidin. Hepcidin is the molecule which is produced by the liver in response to inflammation that inhibits the absorption of iron from the gut. Erythroferron, which is synthesized by the liver in these patients with beta thalassemia, inhibits the production of hepcidin, thereby facilitating the iron absorption from the gut. Okay. That results in hemosiderosis. In one way to correct the anemia and improve the clinical manifestations and improve the well-being of the individual, okay, we give the transfusion. Transfusion results in the iron overloading of the individual, and there is increased absorption of the iron from the gut added to the iron load in the body, thereby resulting in the features of hemosiderosis, organ dysfunction, and morbidity and mortality. Well, look at this slide. This is the patient with the beta thalassemia major with peripheral blood smear. There is hypochromasia, presence of target cells, anisocytosis, phyclocytosis, eosinophilia, eosinophilic stippling, etc. These are the features of the peripheral smear in a patient with beta thalassemia major. And this slide explains the pathogenesis of beta thalassemia. What happens in the beta thalassemia? There is impaired beta globin chain production because of the mutation of the gene controlling the beta globin synthesis. there is relative excess of alpha chains. Results in abnormal erythroblasts with alpha chain tetramers, etc. Most of these cells they die in the bone marrow, resulting in ineffective erythropoiesis, which is the hallmark of beta thalassemia. That results in anemia. Okay, and few abnormal cells enter the circulation. Precipitation of alpha globin aggregates within the membrane that damage the membrane, and there is extravascular hemolysis in the spleen because these abnormal cells are subjected to hemolysis in the spleen and ultimately results in anemia. That results in tissue hypoxia, elevated erythropoietin produced by the renal tissue. That results in expansion of the bone marrow, ultimately resulting in skeletal deformities. Erythropoietin further stimulates the extramedullary hemopoiesis that results in the hepatosplenomegaly. There is increased erythroferron synthesis. There is suppression of hepcidin synthesis, which facilitates the iron absorption from the gut. Ultimately results in systemic iron overload, added by blood transfusions because the anemia is transfusion dependent. This results in a secondary hemochromatosis, and there is organ dysfunction, cardiac disease, and death. This is the pathogenesis of beta thalassemia, and the course of events occur just because of the mutation of the gene that controlling the beta globin chain. Okay. Having understood the pathogenesis, how does this patient present to you? At the time of birth, these infants are normal. Okay. There's no clinical manifestations, no anemia, no jaundice, and baby is looking healthy. Then in course of time, when there is fall in fetal hemoglobin and there is no adequate synthesis of beta globin chains, there is a dramatic fall in the hemoglobin content, and the individual suffers from chronic hemolytic anemia. The clinical manifestations can be summed up into general features of anemia, features specific to beta thalassemia major, and features of transfusion hemosiderosis. You can group the clinical manifestations into three categories. Anemia of general features, that is growth failure, easy fatigability, exercise intolerance, and when you examine the child, there is pallor, jaundice, and features of congestive heart failure. When the anemia is not treated and there is a gradual drop in the hemoglobin content, ultimately child suffer from cardiac or congestive heart failure. Coming to features of specific to beta thalassemia major. Because of the persistent hypoxemia secondary to the anemia, there is expansion of the marrow space secondary to the elevated erythropoietin levels. That results in the bony abnormalities. Look at the face. There is thalassemic faces with frontal bossing. You have seen the picture. Depressed nasal bridge, maxillary prominence, and tail looks wasted. Cachexia because of the hypermetabolic state. Pathological fracture because of thinning of the bones, especially the long bones. Massive splenomegaly occurs secondary to extramedullary erythropoiesis. Okay, these are all secondary to the hyperplasia of the erythroid tissue in the bone marrow. And features of hemosiderosis. When the child had been suffering from chronic anemia and hemoglobin is falling down, and as a result of hemoglobin there is hypoxia and resulting in hyperplasia of the erythroid tissue, resulting in the bony abnormalities and the pathological fractures. To prevent this situation, you have got to transfuse the patient, and repeated transfusions results in iron overload. If you maintain the hemoglobin content around 9 to 10 grams per cent, the complications resulting in the secondary to the erythroid hyperplasia and the bony abnormalities can be prevented. In order to do that, achieve that, we have to give the blood transfusions, and the patient should be on regular transfusions, which may result in iron overload. So it is a crucial decision whether to provide the child and treat the child with blood transfusion or not. You treat the patient with blood transfusion, there is risk of iron overload. If you do not treat the patient with blood transfusions, they are going to be the serious consequences, and child may die of hypoxia and congestive heart failure and death. At the same time, if you provide the patient with blood transfusions, over time there is iron overload and hemosiderosis and its manifestations. So that is the reason why you have got to decide the steps of management. Okay, so you treat the patient with blood transfusions, provide the iron chelation in order to reduce the transfusion related hemosiderosis. Then this could be the plan of management that we are going to talk in course of time. What are the features of hemosiderosis? There is hepatic dysfunction because of the iron accumulation, and hypothyroidism, hypoparathyroidism, growth hormone deficiency, diabetes mellitus, gonadal failure, adrenal failure, cardiac dysfunction. These events occur in a chronological order. If the transfusions are given continuously or the patient is on regular transfusions, one transfusion every month or every 2 to 3 weeks, depending upon the degree of hemolysis and the severity of anemia, and nearly in a year or so, there is hepatic dysfunction. And endocrinopathy sets in over a period of 4 to 5 years in the patients on regular transfusion. Over a period of 8 years, there is cardiac hemosiderosis, and child may develop features of cardiac dysfunction. Now look at this child. There is massive splenomegaly and anemia. This is the picture showing the target cells and macrocytic anemia. And this is the X-ray chest showing cardiomegaly secondary to anemia and congestive heart failure, probably associated with cardiac hemosiderosis. So this is the child with beta thalassemia major, X-ray skull, lateral view showing the Iran and appearance. There is a widening of the diplosed space of the skull bones and bridging veins are stretched, showing the Iran and appearance due to erythroid hyperplasia. What is the laboratory workup? Do the hemoglobin, do the reticulocyte count, and there is dramatic fall in the hemoglobin content, very low hemoglobin. It may come down to even less than 3 grams per cent. And reticulocyte count is relatively low when compared to degree of anemia. And reticulocyte count will not cross more than 68%. There are nucleated RBC with macrocytosis. There is elevated serum bilirubin. Serum iron is increased. Total iron binding capacity is low. Bone marrow shows erythroid hyperplasia, and radiographs they show the skull bones show Iran appearance. There could be, if you take the long bones, there could be pathological fractures, and there is widening of the marrow space. You go for the hemoglobin electrophoresis, there is elevated level of fetal hemoglobin. There could be FA pattern or FAA2 pattern. It is said India has an estimated 100,000 thalassemia major patients and over 35 million carriers. This is the hemoglobin electrophoresis showing the elevated HbF level and elevated HbA2 levels. This is the pattern you see in the hemoglobin electrophoresis in a patient with thalassemia major. A2 is 3 to 8%, whereas normally it is less than 2%. Maximum is 2.5%. HbF is always less than 5%, and it is elevated beyond 20 to 40%. HbA is only 50 to 70%. This is a case of thalassemia. But in thalassemia major, HbA is still low. Probably it is thalassemia intermediate or something like that. Well, this child had been on chronic transfusion therapy, regular transfusion. Coming to treatment, transfusion therapy. In order to reduce the morbidity and the bony deformities secondary to anemia. We plan the transfusion therapy. It is the called as the scheduled transfusions. That is regular transfusion once in every 3 to 4 weeks in order to maintain the hemoglobin level around 10 grams per cent. Well, iron content of 1 ml of blood is equal to 1 milligram. Okay. And every time you transfuse, you are loading the patient with around 250 milligrams of iron. There is no exit for iron from the body. It gets accumulated in the liver, endocrine glands, and ultimately myocardium. Okay, resulting in the hemosiderosis, causing the organ damage. Then supplement with folic acid. Hydroxyurea is not that effective for patients with beta thalassemia, but there have been trials to treat the patients of thalassemia intermedia with some amount of response. Avoid iron containing foods. Counsel with the parents. Explain them to avoid the iron containing food. Provide good nutritive diet. Okay. And iron chelation therapy. So we have got the deferoxamine, deferriprone, and deferacirax. Deferoxamine has got the good clinical efficiency. It has been used for a long time, given subcutaneously. Okay. And deferacirax is used for cardiac hemosiderosis. And splenectomy is another procedure that is carried out for children with massive splenomegaly and episodes of hypersplenism. Ultimate cure has been promised with hematopoietic stem cell transplantation. We should get the HLA matched sibling, and the hematopoietic stem cell transplantation has promised the cure for these children with beta thalassemia. Then what are the benefits of transfusion therapy? With regular blood transfusions, there is improvement with regard to growth. There is less chances of bony changes and bony deformities. There is a correction of anemia. Okay, and scheduled transfusions are given at 3 to 4 weeks intervals in order to maintain the hemoglobin content between 9.5 to 10 grams per cent. Then, as I told you, hydroxyurea has got limited reports for use in thalassemia major. Used in thalassemia intermediate at low dose, that is 10 milligrams per kg per day, improves hemoglobin content, reduces the chances of venous thrombosis. Do not give in higher doses. That may result in toxic effects like agranulocytosis. Iron chelation. When do you give iron chelation? Monitor the patient with a regular estimation of serum ferritin. When the serum ferritin level is more than 1000 nanograms per ml, and hepatic iron, if it is more than 2500 micrograms per gram dry weight of the liver, okay, start the chelation. Chelation is toxic at low iron stores. Don't do chelation therapy when the serum iron levels are low. Commonly used drug is, well-tested drug is deferoxamine, given at 20 milligrams per kg body weight per day, increased to 60 milligrams per kg per day, given subcutaneously overnight. Okay. Deferacirax is a oral drug given at 25 milligrams per kg per day. Deferriprone is given for cardiac hemosiderosis, It's orally administered in a dose of 20 milligrams per kg per day. The ultimate step is hemopoietic stem cell transplantation. Success rate is good if performed under 15 years of age. Cure rate is at least 90%. Okay, you need HLA matched sibling, and we do the prior myeloblastic, myeloablative. Prior myeloablation is required to condition the patient, and there should not be hepatomegaly. The children are subjected to hemopoietic stem cell transplantation. No excessive iron stores. These are the precautions you have got to take while putting the patient for stem cell transplantation. Splenectomy is done in children with massive splenomegaly with episodes of hypersplenism. And other indication is falling hemoglobin, raising transfusion frequency. Okay, these are the indications. There is massive splenomegaly with episodes of hypersplenism, falling hemoglobin content, and there is raising frequency of the blood transfusions. Okay? These are the indications for splenectomy. The risks of splenectomy are sepsis, venous thrombosis, stroke, leg ulcers, and pulmonary hypertension. And there is always a risk for bacterial infections, especially capsular bacteria. You have to vaccinate the individual against the pneumococci and other infections prior to splenectomy. Then monitoring. And children on regular transfusion therapy for beta thalassemia major should be monitored with regard to cardiac and endocrinal and psychological well-being of the patient and the family. We need a support team in order to manage the children with thalassemias. 8 years after the transfusion therapy, cardiac hemosiderosis should be evaluated through cardiac MRI. Endocrinal. 3 to 5 years after the initiating the chronic transfusion therapy, there could be endocrinal dysfunction secondary to the hemosiderosis. So endocrine functions have to be assessed with regard to diabetes mellitus, traces the pancreatic function, and growth hormone, and the thyroid functions, etc. should be carried out nearly 3 years following the transfusion therapy. And psychological evaluation of the patient as well as the parent, it should be monitored regularly. Well, thank you very much for patient listening. This is the genetic hemolytic anemia. You see, the gene mutation is resulting in the reduced synthesis of hemoglobin by the erythropoiesis. Okay, quantitatively there is fall in hemoglobin because of the reduced synthesis of the globin moiety of the hemoglobin. That results in the premature lysis or destruction of the RBC before they are released into the circulation. And erythropoiesis is defective, ineffective erythropoiesis. As an attempt to increase the synthesis of hemoglobin, there is hyperplasia of the erythroid tissue, widening of the myelospace, thinning of the bones, deformity of the deformity of the long bones, frontal bossing, there is prominence of the zygoma, thalassemic faces, and when you attempt to give the transfusion, there is danger of excessive accumulation of the iron in the form of hemosiderosis and organ dysfunction. And it should be helped by chelation therapy. How many families are within the reach of advanced management like stem cell transplantation? Most of the patients that get the beta thalassemia are from hilly areas or tribal areas, okay, or malarial zones. And the people who cannot afford the advanced management, the children suffer, the patient parents, they face a lot of problems in order to get their children for transfusion therapy. And a team of workers, social workers, and pediatricians, psychologists are required in order to manage this set of patients appropriately. Okay. Ultimately, there is no cure for this disorder. It is associated with the chronic morbidity, ultimately resulting in death. So, counseling of the parents is so important, and well, testing for the screening for the genetic screening of the parents is very important in order to know the risk of the children getting this genetically transmitted hemolytic anemia. Okay, yes, this all is possible when you effectively counsel the parents, screen them for the genetic mutations. Okay, then properly manage the children with this particular chronic hemolytic anemia. Well, those who are able to afford the stem cell transplantation, that is the ultimate step for these patients with regard to curative treatment. Thank you very much once again for patient listening. We'll meet you again in the next class. Until that time, bye bye and thank you.